Start. Are you ready?
Yes, I am. Do you want me to start, or are you going to say anything? No, just me.
I was going to do that. Welcome, everyone. Thank you for joining us tonight for August Dercum's Disease Roundtable. I'm Lauren, I'm your host, and my lovely co-host Juanita is here tonight. Tonight, we bring you a presentation from Linda Ann Kahn on insulin resistance in Dercum's disease. Linda Ann has been an advocate for Dercum's lymphedema and lipedema patients, as well as being internationally and board certified lymphedema therapist. We are so grateful for your time and advocacy. Tonight on our panel, speaking of advocacy, we have Dr. D'Angelo and the Dercum's disease founder, Ray Wood. And with that, I'll hand it over to Linda Ann so she can start.
It's an absolute pleasure and honor to be here. I was just sharing with the panelists earlier. I just came back from an incredible conference on the fascia, an international conference, and I spoke about the lymphatic system and connective tissue diseases, and in particular lipedema and Dercum. So more on that another time. But today we're going to be talking about insulin resistance in Dercum's disease. We're going to talk about how metabolic dysfunction, chronic inflammation, and gut dysbiosis contribute to the progression of connective tissue diseases and disorders, and in particular Dercum's, and how the role of chronic inflammation in the disease progression. We're going to talk about the central role of insulin resistance, altered fat tissue behavior, and inflammatory processes in these conditions. And then I will end with a practical, holistic, integrative approach to manage Dercum's and what we can do to help with insulin resistance. I do just want to clarify, I'm not a doctor. So I'm not giving any medical advice. I do a lot of research, a lot of studying, and I've been practicing for over 35 years. I have lipedema stage 1 myself, and about 20 years ago, I met Dr. Karen Herbst in San Diego, and she started referring patients to me, and then she started referring patients with Dercum's. I knew nothing about Dercum's at that point in time. Now there's a lot more awareness and more research. We need more research on Dercum's. And thank you to all of you for doing all of this and for helping us to help Dercum's patients and educate and support. So I know you all know what Dercum's is, but I just put this slide in. We know that there's painful subcutaneous tissues. The lipomas can be painful. There can be generalized pain. There's always inflammation. And there's very often overweight or obesity, but not all of my Dercum's patients are overweight. But we'll talk about that today. And there, of course, there are psychiatric disturbances, sleep disturbances, and anxiety. And unfortunately, rapid heartbeat and shortness of breath comes with Dercum's disease. And then insulin sensitivity leading to insulin resistance, and then to diabetes. So we're going to focus today on the obesity and the diabetes. And there can also be bloating and constipation. And I'm sure that there are other conditions that unfortunately you guys are suffering with. But we'll talk today about obesity and metabolic abnormalities and how that affects hypertension, diabetes, and insulin resistance. We know that patients with connective tissue diseases face a combination of metabolic dysfunction. There's also altered fat behavior, tissue behavior. There's gut issues, and very often resistance to traditional weight loss methods. It's a unique pathophysiology of this condition, which is genetic, hormonal, and systemic. And we're learning more and more all the time. It's complex, and we need to understand the complex interactions of these connective tissue dysfunctions. Ehlers-Danlos loss is a connective tissue dysfunction. We won't be focusing on that, but we know many patients with Dercum's have Ehlers-Danlos loss. But there's inflammation, there's inflammatory cytokines, macrophages, and interleukin-6, IL-6, IL-10, TNF-alpha, all these inflammatory markers. And then the immune system is involved. So there are lymphocytes, fibroblasts, and I learned at my conference a lot more about the fibroblast than we already know, and the function in wound healing and the function in the tissue, and then the mast cells. So all of this is very, very complex, and we need to know that. I wanted to talk just a little bit about a term that has emerged in the functional medicine world, and it's called inflammaging. And we know that with Dercums, there is a lot of inflammation, but inflammaging, which is a new word, I love it, that chronic low-grade inflammation develops with age and contributes to many age-related diseases. And when inflammation persists for a long period of time, it can become harmful and contribute to the development of metabolic dysfunction. So what is really happening in Dercums? We need to know more. Is it a combination of inflammaging? Is it the genetic component of the Dercums? Is it a combination of both? It's something I'd love to discuss, with the panel. But you can see there's aging, there's inflammation, metabolic dysfunction, and it all goes round. Age-related inflammation. So when that happens, there's a cellular senescence in the fat tissues, and they're pro-inflammatory. The cells start to die. There's reduced autophagy, which is the self-cleaning mechanism of the cells. And then there can be oxidative stress. And all of these impact Dercum's disease. And then from that, we get something called meta-inflammation. And this is what I believe is happening with Dercum's disease. It's metabolically triggered inflammation. And then there's more macrophages, which are the inflammatory cytokines, and the adipocytes start to die, and there are more of these inflammatory markers. And I'd love to talk to Dr. D'Angelo afterwards more about that. And so metabolic and adipose tissue challenges. We need to understand the role of insulin resistance and metabolic dysfunction to manage Dercum's disease, and how insulin resistance comes into play with that, and how that may become diabetes. It was found, and there are more studies on lipedema than there are on Dercum, so I will be citing some of the lipedema conditions, but many patients with Dercums do have lipedema as well. But lipedema patients in the study exhibited higher plasma insulin levels, indicating impaired insulin sensitivity. And that led to hydroproteic fat. The fat cells increased, and inflammation. And then in the adipose tissue dysfunction, again, I got to repeat again, there's inflammation and fibrosis, and that contributes to the metabolic disturbances. So in addition to the lipomas that you feel, there's also a lot of fibrotic tissue and hardened tissue. And when I'm working, doing my manual lymph drainage and my myofascial work, I can feel all of that in the tissue. And so when we have metabolic disruption, it impacts the gut. And then there can be gut dysbiosis and leaky guts. There's something called LPS, which goes into the bloodstream. And then these bacterial endotoxins induce inflammation, and then there can be insulin resistance. And so I just thought I would do this drawing so you could just understand a little bit more. There's insulin sensitivity, and when a person is eating too many foods that are converting into glucose, so there's more glucose and more glucose. But as the glucose comes, then the pancreas secretes insulin, and so there is insulin that moderates the glucose in the body, and it calms down that glucose in the body. But if you are continually eating maybe every 2 hours, or eating a lot of, I hope nobody here on this call, high fructose corn syrup and all what am I talking about? My brain is just thinking ahead of myself right now. But all the foods that are, oh gosh, I can't think of the word. all the carbohydrates, the high carbohydrates and those metabolically active foods with the white carbohydrates, and there's too much of it, there'll be so much glucose that eventually it'll go to the cell and knock on the cell and say, let me in, and the cell will say, sorry, there's too much of you, there's too many, you're not coming in. And that's now called insulin resistance, where the cells do not take up the glucose that is there. What's very interesting, what I've been researching and finding is everybody looks at glucose levels, but it's not the glucose that's as important, because as the glucose levels are high and that insulin is secreted, it's okay, but insulin starts increasing and increasing, and it can be a couple of years of going like that before the insulin gets to the point that you're going to see that it's a problem. So we can't only look at glucose. And so insulin sensitivity measures how well the cells respond to insulin to regulate the blood sugar. And insulin resistance occurs when the cells have a reduced response to insulin, leading to metabolic issues. And insulin resistance is closely linked to metabolic disorders like type 2 diabetes and obesity. We know that chronic inflammation is a driver of insulin resistance. There's chronic inflammation, unfortunately, in lipedema, in Dercum's patients. Genetic influence can play a role, and it's very important to do regular exercise to help the insulin uptake and improve the glucose uptake in the muscles. And a balanced diet supports optimal insulin function and sensitivity. And that's really, really important. And I know that is so difficult for so many of the Dercum's patients, because either there are not enough funds to get a lot of these foods, or you're not active enough to really prepare them. It could be so many things, and I do understand that. But perhaps in another roundtable, we can have a discussion about how to easily prepare and to do things easily, and nutritionists maybe in a lower income way, so that patients can still get the good nutrition that they need. When there's excess body fat and chronic inflammation, that will negatively affect insulin sensitivity. And so just remember, the insulin sensitivity becomes insulin resistance, and then that turns into diabetes. But when you have a high amount of insulin in the blood, which is what I was describing to you, it's called hyperinsulinemia. And the pancreas will release extra insulin, which is a major cause of chronic inflammation and insulin resistance. And so we need to work with it very much so with Dercum's disease, and have a low glycemic index diet to avoid fluctuations in the blood glucose and insulin levels. Maybe we can have a discussion about this after I've given my talk, but there isn't time to do that now. Many patients have obesity, and this is a normal fat tissue, and there are some macrophages in it, but when the fat tissue, when it's obese, there are more pro-inflammatory fats, adipokines, and macrophage type 1, and the immune system gets more involved, and you get more inflammation. And then this adipose tissue, the fat tissue, becomes an active inflammatory organ, and it releases pro-inflammatory cytokines that I've been talking about. Those are the cells that contribute to the inflammation. And so the fat cells in lipedema and Dercum's produce these inflammatory cytokines, and that exacerbates the metabolic dysfunction. And that's what we're talking about, is this metabolic dysfunction. I know this is a very busy slide, but it just shows you there on the left side, the obesity. Chronic inflammation adds to the obesity. The obesity triggers the chronic inflammation. That worsens insulin resistance, and the insulin resistance worsens the chronic inflammation, and then you get these inflammatory markers that I spoke about. And the metabolic abnormalities are being overweight or obese, hypertension, diabetes, insulin resistance, and dyslipidemia, which are frequently observed in individuals with Dercum's disease. And this can impact overall health and well-being. So there is this connection to type 2 diabetes. Insulin resistance will lead to type 2 diabetes, and metabolic syndrome, which includes hypertension, dyslipidemia, and central obesity, are all linked to insulin resistance. Don't those foods look delicious? And with metabolic dysfunction, there's a disruption in the normal metabolic pathways that involves insulin resistance. There's also mitochondrial dysfunction, and the mitochondria are responsible, they're in the cell for the energy production. And so many patients with Dercums are tired, are chronically tired. There's mitochondrial dysfunction with this low-grade inflammation. From that, there is a risk of obesity, diabetes, cardiovascular issues, and metabolic syndrome. And so that can be very much so in Dercum's disease because of that inflammation. So just to summarize that, obesity is closely associated with lipedema and Dercum's disease, possibly exacerbating the pain and inflammation and contributing to insulin resistance. I just thought I would summarize all that stuff that I've just been telling you about. And research has shown that Dercum's disease involves multiple painful lipomas with metabolic abnormalities such as insulin resistance. We really need more research so much with Dercum's. Again, it's another busy slide, but basically it's showing you how obesity leads to chronic inflammation and all these disorders of lipid metabolism and insulin resistance and type 2 diabetes. And NAFLD is non-alcoholic fatty liver disease. And that can also, all of this actually can even lead to osteoporosis. The dysfunction in obesity, there are inflammatory cytokines, which are these inflammatory molecules. And then there's an immunoresponse. I just put that in so you could see the study because I wanted to bring some study. And then when there is metabolic alterations contribute to weight loss resistance. In lipedema, it's really very difficult to lose weight, and also with Dercum's patients. Insulin resistance is connected to lipedema and Dercum's disease, and the insulin resistance itself will alter fat metabolism. So one thing leads to the other, and goes back again. And that further drives the development of these conditions and all of the conditions that are comorbidities with Dercum's disease. And so what I wanted to talk about is some strategies and interventions to help with all of this. And there needs to be a circle of care. And I understand that many Dercum's patients are out in remote areas and they don't have access to practitioners. And my heart just goes out, and I just say, reach out to your community, because I think I'm going to cry now. This Dercum's Disease Answers group is amazing. Everybody wants to help. Everyone is there to help you. And I know that everyone on this panel we're here because we want to help. If I can be of help, if you want to email me anything that I can help you with, I'll be happy to do that, or put you in touch with the right people to do that. But we really need patient-centered care, where we need to help you to be empowered to have a combination of holistic care and conventional medicine, because many of you are on medications and you need to be, and there's pain and there's inflammation, but there is a lot that can be done holistically, and working with lifestyle modifications, with foam rolling and working on the fascia, and really helping everything to flow, and other tools to do to calm the vagus nerve with deep breathing, and calm all of that, and with a mind body and mindfulness and the complementary therapies. So I could talk about that all for about 2 hours, but we won't. But we want to address the root cause of this metabolic dysfunction with an anti-inflammatory diet to help that systemic inflammation. And I know it's difficult, but you start with one thing, just one thing at a time, and slowly do that. And we can help you with what to do in place of that bread, that inflammatory bread. What can you do instead of the pasta? You can have pasta that's made from quinoa that's not as inflammatory. And then to work on the gut microbiome with probiotics or prebiotics to help a healthy gut flora. I really love sauerkraut, but if you do have mast cell activation, which many of the patients do, that you wouldn't be doing that. And then there are medications that are used to improve insulin sensitivity. Some of the doctors will prescribe metformin, and then the GLP-1s to enhance insulin secretion. And that's another whole discussion, isn't it, Dr. Stephen? We can talk about that forever. Berberine can lower blood sugar and help with insulin signaling. And a low glycemic diet and a low load of glycemic can to prevent these blood sugar spikes. And I would urge you to consider a continuous glucose monitor. You can get the doctor to prescribe it. It was a game changer for me. I have stage 1 lipedema, and I had just put on weight, and I lost 10 pounds in the last 4 months, just putting on the glucose monitor, being really aware of what I was eating, because it's different for everybody, and how it was spiking, and I was controlling that. So I would really urge you to consider that. And then physical activity, even if you're in a wheelchair or a walker, the things you can do holding onto the wheelchair and onto the walker, we need to move, and that will help as well. And then check with the doctor the inflammatory markers and insulin resistance markers, and then to address sleep disorders, which I know is very, very prevalent in this community. I have found that time-restricted eating or intermittent fasting can help the insulin sensitivity, or just spacing your meals out 4 to 6 hours. And with the intermittent fasting, you eat with, I know they say, how long are you fasting? I don't look at that. I look at what is the window of time that I am eating. And if you want to lose weight, it should be a 6 to 7 hour window of time. If you want to just improve your markers, you do an 8-hour window of time. So you start at eating at 10, and then you stop eating 8 hours later. Anti-inflammatory foods, omega-3 fatty acids. If you can't get hold of the wild salmon, you can have walnuts, flax seeds. And then blueberries are polyphenol rich. Fiber is really important, that will help the gut. Artichokes and asparagus and garlic, those are prebiotic fibers. And then to have quality proteins, grass-fed beef if you can get hold of it, pasture-raised eggs, and lentils. Lentils are great fiber and wonderful protein and don't cost a lot and are easy to prepare. Trader Joe's actually sells lentils that are already cooked. And then low glycemic carbohydrates such as beans or broccoli or cauliflower or quinoa, which is actually a seed. And that will help to reduce the inflammation, help with antioxidant production, and help with the gut. There we go. And a low carb diet would help with all of that. So we want to help with fasting insulin levels and helping with glucose tolerance. So we want to have a diet that's going to help not to spike glucose, and improving the gut health and intestinal barrier support. You can test zonulin, vitamin D, and then work with the microbiome with all these foods. That will all help with insulin sensitivity. Sorry, I need to finish, I think, in a few minutes. But these are just supplements that I put together that can help to improve insulin sensitivity. So I encourage you to take a picture of this, because these berberine, which I already mentioned, alpha lipoic acid, which helps oxidative stress, magnesium, chromium picolinate will help insulin function, and cinnamon will lower fasting blood glucose, and you can use cinnamon powder. Resveratrol will help that mitochondrial dysfunction. Curcumin helps with inflammation. Omega-3 fatty acids, and vitamin D is really important to take. I think I'm almost finished. So flavonoid foods, green tea is great, having your vitamin D and reducing your stress levels. And so to take an integrative approach to help with metabolic and inflammatory dysfunction, and the role of functional medicine in treating these conditions with personalized care. and targeted metabolic interventions that address the root cause of insulin resistance, chronic inflammation, and altered fat tissue rather than just focus on weight loss. So, key takeaways would be the metabolic dysfunction, an integrative approach, and I'd want the patients to be empowered to advocate for yourself for a more personalized and comprehensive care and put the puzzle together because your needs are different to somebody else's. We all have unique needs, and reach out to your community for help. And you can and need to play a role. So that's what I have for you today. I hope this has been helpful and it wasn't too technical.
Linda Ann, that was incredible. So valuable. I'd like to let the panelists ask some questions before we turn it over to Juanita for audience questions. Does anybody have any questions?
Just kind of a quick comment. You touched on so many really important things here, and just the overall theme I'm seeing in Dercum's disease and a lot of fat disorders is that rethinking what adipose tissue is in our bodies. And for so long the public perception has been that our adipose tissue is just energy storage, and that's really all it does. But we're seeing now, especially with these diseases, that it does so much more. And if you really want to, take control of your disease, the way that you have to approach it is to do these things that have these long-term effects and may take months to years to really see the effects from them. But that's what's really going to help in the long term. And that the short-term issues, focusing on the pain, focusing on the individual growth, like, yes, that's so important. But you have to also couple that with all these long-term interventions to really get the disease under the control. And you're treating an organ dysfunction, and really approaching it that way and trying to get doctors to see it that way is going to change the way we look at everything. So thank you. You just hit on so many important points.
It really was wonderful. Go ahead, Ray. I heard you.
Linda, I wonder, as I've been doing some research into this topic, I must admit, I really did not understand what insulin resistance means. It may not mean that you even have diabetes. It is far more complicated. I think sometimes I kind of do this sometimes. Sometimes we might dismiss things because we don't necessarily understand what the impact is to us. Is there a way to kind of talk about what this insulin resistance might be doing? What kind of symptoms people might have, if that's an appropriate conversation?
Sure. Well, with the insulin resistance, it's pre-diabetes. I mean, it leads to diabetes. So there can be fatigue, there can be dizziness, you'll get bloated. I mean, there's all of these things that can happen from that insulin resistance, and that's from having too much glucose in the body. But it starts with the insulin sensitivity that is there. Lipedema patients have insulin sensitivity, and so do Dercums from the research that I found. And then that becomes insulin resistance when there's too much of the glucose in the body. So that can affect everything about us, our digestion, our energy levels, and then the next step is diabetes. So I don't know, can you answer that better than I did, Dr. D'Angelo?
No, you hit it right on the head. It's such a complicated system that is really presented as kind of a binary. Either you have diabetes or you don't, but there's this whole middle ground of decreasing insulin sensitivity that leads into the diabetes range, where a lot of us fall. Pretty much all of us that have trouble losing weight have some degree of insulin resistance. A lot of us that get really bloated after meals and have all these issues with their gut have some degree of insulin resistance, and it explains a lot of our symptoms. I think when we're digging into this more and more, we're really seeing that we try to attribute everything to the lipomas, but it's not. It's a whole system dysfunction of the adipose tissue, and this is just one of the many factors that goes into it.
I love that you said that, because it's a whole system, and it's like, also, we can't just focus on the weight loss. We have to look at everything and the underlying aspects of this. So it is a whole system, and especially with Dercum's disease, where the heart is involved, the blood pressure, the brain, there's so much involved in it. So it is a whole system. And if we could get to the root cause of where it is and treat it from there. And honestly, the diet, it's so important, but it doesn't have to be overwhelming. You just, I've been trying to teach my sister. She has lipedema and she doesn't listen to me. And finally, she went to the doctor, integrative doctor. She came back, she said, the main problem is sugar. I'm like, okay,
Yes.
hallelujah. So,
And we're emotional eaters a lot of times, right? Trauma, emotions, we go to food to make us feel better. But unfortunately, that does the reverse.
I feel like I would be remiss if I did not mention that not all of Dercum's percentage of us are lean.
yes.
Not everyone with Dercum's has the same body mass. And so, I think what I take away from this, as I've learned more and more about it, is that even though for me, I seem lean, I can still eat better. I mean, I think it's so important. I think sometimes we want to see the limit rather than seeing the ability to take control. And really, that's so important. Dr. D'Angelo said that. This is a way we can wrest back control.
And you can be lean and still have insulin resistance.
Absolutely.
So, yes.
Well, it looks like we have some questions now. So are we ready to get started on that? Answering questions here. We have Heather. You have a question for Linda Ann. Would you rate veggie meats as healthier or less healthier due to the processed nature compared to meats?
I don't like those veggie meats at all because they are processed. The word I couldn't think of when I was talking with the ultra processed foods. So these are not ultra processed, they are processed foods. And so we don't want to have processed foods because that's not good for your detoxification pathway. So I do not like those veggie meats. And if you prepare plant-based and vegetarian foods, you really don't need all of those. So my answer is no. Yes.
Thank you. Thank you. And I think a lot of us started out on that path. Like with fibromyalgia, they tell you that stuff and we bought into it. Not anymore.
Yeah,
Anna,
I like to look to see what are the ingredients. And
yeah,
Dr. Ben Bickman always says, do not eat anything that comes from bags and boxes which have barcodes on them. So
such a good point.
Isn't it? The veggie meats are not like that way, but still avoid anything from bags and boxes with barcodes, because those have all the ultra processed foods and additives.
Anna would like to know if we know of a local doctor to diagnose or treat Dercum's in Miami, Florida. And I want to say before anybody answers that is that we have a lot of Dercum's people in Florida. So even if we can't give you some names here, we'll have some in the group too. But Lauren, do you have anything for her maybe?
I think there's Dr. Correa that's in the south of Florida, but I don't know if she's accepting any new patients right now. But she's in the list in the
There
group.
you go.
Dr. Correa?
Yeah.
I'm sorry, I didn't hear that. She's not accepting new patients?
That's what I thought. I had feared that she wouldn't.
That was going to
No,
be
I think
my
she's
suggestion.
saying it. I think Lauren is saying she doesn't know Ray, so we're not sure.
Yeah.
Okay.
You might look up Margaret Correa, Korrea. I can't guarantee she's accepting Dercum's patients.
It's with a C.
It's with a C.
Oh, I'm sorry.
C-A-R-R, yeah.
Yeah.
C-A-R-R-E, yeah. Yeah, I know her, yeah.
And Anna, if you go to the file section in our Dercum's disease answers group, there is a list of doctors by state. And if you don't find it, go ahead and post it, put a post in our group to remind us, and maybe we can get some other people to answer that too for you. Okay, moving on to Kathy. Should Dercum's patients not have liposuction? I've had one so far, and new angioplomas are growing back only 4 months later.
So I have worked on many patients who have Dercum's disease who have had the liposuction. It really depends on your individual case because everybody is different. I know with the patients who've had the lipomas excised, they usually grow back unless you take out the tail. Dr. Herbst showed us at one of the conferences many, many years ago, she had taken out in her research, taken out a lipoma, and she took it out by the tail and pulling, that wouldn't grow back, but the others would. But with the liposuction, it depends what method the doctors are using. There are many methods. And would it dissolve those lipomas? Maybe not. Some of the doctors are squeezing out and they're getting them out. Others are using a VASA, which is like an ultrasound to so-called melt it. They don't always come out with the liposuction. And these liposuction surgeries they're difficult. They're very difficult. I work with a lot of patients with those. And you really need to have manual lymph drainage afterwards and prepare before anti-inflammatory.
That's true.
And wear your compression afterwards so that you're not giving
And when you
space to
compre-
fill back up with lipomas.
Oh, absolutely. And pneumatic compression, definitely.
But keep up with all of your therapies even after.
I also would add that it really depends on the surgeon. You know, there are some that I know of and I've seen actually present where they do a liposuction and it's not the most pleasant thing to see, but they squeeze them out after. And they just come rolling right out. I know everybody is different. And, you know, some of us, including myself, I talked to a surgeon, whatever they're called, cosmetic surgeon. And he's like, no way, I'm not cutting you. I wouldn't know where to even start. And I'm glad he did that. But, you know, I do think sometimes, depending on the surgeon, and if you shop properly and talk to people well, you may find an answer.
The tail, that was a key, though, that I think is missing in a lot of the doctors.
Just
They
keep
don't
asking around. Just keep asking around.
Yeah.
And the
So-
doctors who do squeeze the fat out, usually they'll send you for hyperbaric oxygen for about 3 treatments afterwards, because you look like you come out of the back of a bus afterwards, but the hyperbaric heals everything. So
I've not heard that before. That's
Yep.
new for me.
Yep.
I'll have to research that. Okay.
just the doctors who do the squeezing out, because it's
Sure,
really, yeah, and you actually can see the fat coming out and the lipomas, and yeah, but they're different doctors who have different techniques.
Yeah, and again, I just want to add on to that. You know, it's not going to be a curative procedure, and I think that's the important thing to remember. So that it's, again, the treatment of this disease is so individualized, and you have to do what's right for you. So if this is something that is going to get you moving and going to help improve your quality of life, you know, on your path towards disease management, absolutely go for it. But if you're looking for something to, you know, take away everything and make sure they never come back, it's not going to do that for you. It's not going to be an instant fix. So anything you do, even if you remove all the lipomas, even if you remove all the tails, you're still going to have this underlying insulin resistance and adipose dysfunction remain after that.
I'm so glad you said that, Dr. D'Angelo, because then you go back to having an anti-inflammatory way of eating and doing exercise the best way that you can, but moving. I tell all my patients, I like people to prepare for about 6 months before even having surgery. And then, because you're still going to have this condition after the surgery, you just might have less pain. Most people do have less pain afterwards. And then you need to continue. So you continue with what you've been doing. And then I do believe surgeries can be more effective.
Great. Okay, we have Kim. Linda Ann, I also have MS. Do you have any background or advice for those who also have Dercum's and other autoimmune conditions?
So I actually know Kim. I love her.
Yeah.
I adore her. And you know, as we've discussed, Kim, we want to know if there are more people who have MS and Dercum's disease or other autoimmune diseases plus Dercum's. It would be wonderful to know and to connect all those people together. I manual lymph drainage and working with inflammation is really helpful for MS patients as well. I have worked with patients with that. Very good for the Dercum's. So for both of those together, what we're doing, and sometimes cupping and laser. There's many other things that can be done, but it would be lovely to know if there are any other people in this community who have those two conditions together.
Yeah,
Yeah,
so
that would be.
it's a common, saying in the clinic that autoimmune conditions come in pairs. We don't fully understand them, but a lot of people with one autoimmune condition will then later be diagnosed with a second or a third or a fourth. It's not understood. So there's an aspect of this disease that involves the immune system. And again, we don't know how much that is, if it's a side effect or a main driver or where that comes in. But I think we will see commonly people with multiple conditions. And again, that's also a thing to consider, that, can everything be explained by Dercum's? Can everything be explained by lipedema? Or are there multiple things happening at the same time? And breaking that down really helps.
That, if I might add, I really appreciate that definition, Dr. Stephen. That's really important. I would say anecdotally, Lauren and I and Juanita probably all I know multiple people with Dercum's that also have MS, and when Dr. Stephen said what he said, it's really important to note a lot of us have like stacks of these things. And if we have one, a lot of times we may have another. It used to be thought when I first started looking into Dercum's years ago, it used to be thought, I thought the science was like a really high percent of us were shown to have what do you call that, immune issues. I lost the particular word, but it used to be that was the thinking. I think maybe the science has changed a little bit. Can either of you speak to the prevalence of I'm sorry, I'm losing the word. Somebody help me.
Compromised immunity?
Yes, the immunity issues in the Dercum's
compromised. I
community.
think I got it reversed.
Yeah, that's it. That's it. But it used to be kind of an autoimmune. At least that's what we used to think. And I used to read a lot of science saying that.
Well, it would be interesting to know, with Epstein-Barr virus is a common denominator in MS. And I think a lot of Dercum's patients also have Epstein-Barr virus. And of course, mast cell activation. And there's a lot of crossover that I've seen in my practice between Dercum's and Lyme disease patients.
Yeah.
That has been amazing, because I've had quite a number of patients come to me, and again, I'm not a doctor, but come to me with Lyme disease, and I've examined them and spoken to them in a whole history, and my goodness, I have thought that they had Dercum's disease. And 4 of them I referred to Dr. Herbst. This is over the last few years, and I was correct. There's a crossover. So if there's a crossover between Dercum's and Lyme, and we know that infection can trigger Dercum's. And
yeah, trauma.
or trauma for sure. But is that what happened with MS? Was that the Epstein-Barr virus with the MS that triggered the Dercum's? I don't know that we know.
Yeah. So I think a lot of it has come down to, further understanding the immune system. A lot of this has been with advances in immunotherapy in cancer research. That's where a lot of this understanding has come from. And like most things in science, once you start looking into it a little bit more, you realize how much you don't know and how much simplified your understanding before. And so really, as we dug into the immune system in more depth, we realized there's so much about it we don't understand. And we're coming into a lot of those complexities. And again, starting to recognize that a lot of the immune system is regulated by the adipose tissue, and the adipose tissue's, ability to regulate inflammatory signaling. So whether or not, these are truly related, or if the inflammation from Dercums is causing hyperactivation of these other conditions, or again, it's impossible to deconvolute until we can actually, find some type of diagnostic and then, diagnose people early, instead of trying to catch up like we're doing right now when it becomes so overwhelming. And I think that's also the other complicator is, so many of us struggle for years before we get diagnosed. 10, 15, 20 years of struggling with this disease completely unregulated. So at that point, how do you go back to say what caused what? It's just, it's too complicated right now to give a full answer.
And then at that point, it becomes chronic illness.
Right.
Yeah.
Because it's a whole bunch of things.
Right.
So, yeah.
Okay. Heather asks, is there a panel of metabolic tests, i.e. glucose, insulin, etc., that you would suggest we request from our doctors, or is the continuous glucose monitoring really the best way to go to understand the extent of our issue?
So there's an oral glucose test, which is called an OGTT, that can be done. It's an insulin response test. And then, of course, measure the glucose, which they'll do that, and the HbA1c, that's also a measure, to see that. And then the continuous glucose monitor, they call it the CGM. As I said, it was a game changer for me. It's so amazing. And sometimes doctors prescribe that, and then my patients tell me, oh yeah, I didn't look at anything. They were looking at all the results. No, you're going to do it so that you can be seeing, to monitor for yourself. And yes, you might eat a peach and it'll spike up maybe to 160, but how long does it take to come down? We want to come down within an hour to 2. If it's taking you 4 hours and the glucose is not coming down, then there could be insulin sensitivity, underneath. So I'm just going to say again, I'm not a doctor. I don't give medical advice, but my patients, they come to me and I'd say, what would be good? Ask your doctor to do this, to do that. So I would add that to the panel, to ask the doctor. And then also, in addition to that, you want to look at CRP, C-reactive protein, homocysteine, all of the markers for inflammation that they may not be taking. The other one is a sediment rate.
As well, Doctor, we have in our files this, but Dr. Herbst also has published a pretty good guide for things that you might be able to easily add to someone's diet to impact insulin resistance when you have lipedema or Dercum's disease. If you look into our files, it's easy to find. If you can't find it, just let one of us know. We'll find it for you.
Because if you eat fiber, that will help as well.
Yeah, that's what I mean. There's ways you can regulate this that people may not necessarily safely regulate.
Right.
I mean,
and my friend Bonnie Newland, who's a dietitian, what she says is if you're having a grain and you cook it and you put it in the refrigerator for 24 hours. Now, this may not be good for the mast cell patients, but you do that and then you divide it up into small glass containers and you freeze it. And then you take it out as you need it. And what's happened, it's now become a resistant starch. And that will not affect the glucose the same way as if you had it on its own.
And of course, it's my job to say that we have 10 minutes left. So I would like to try to get through some of these. We have one that says, I didn't get a snapshot of the slide on insulin resistance. Could you review those 3? What I'd like to tell you, Stevenson, is that we will be distributing the slides. And if we could wait to do that and to get your answer, that would be really helpful for us, if that's okay. Because that's a whole, yeah, that slide, if we went back over it, we'd take all the rest of the time. Kim, you are asked, whoop, I'm scrolling around like I'm drunk, and I'm not. One down. Okay. We have, why all of a sudden am I, okay. That one's done. Okay. I'm in Southern California and am waiting for an appointment with a dermatologist to hopefully get a diagnosis. Is a dermatologist the best specialist to meet with for this kind of diagnosis? I'm going to go ahead and say, guys, that Jeff, we have a lot of different doctors that we can. It's kind of like you have to go around. If you're in Southern California, though, you should probably go to Dr. Herbst in Arizona if you can, because that's not that far from you and it's worth it. The money that you spend going everywhere else, in my view, is, it's better just to go to her. She's the research doctor. I left with a 7-page write-up, take to other doctors. I just think that to say that it's one doctor that can do this is not true. You're going to have to decide in your area, the doctor. We have endocrinologists, we have internal medicine, we have cosmetology, we have pain doctors, right? There's all kinds of doctors for that. And then look in our files for a doctor, for the doctor list, and see if you can find ones in Southern California if you cannot go to Arizona.
Yeah, you might even consider payer type as well. If you ask specifically, you'll get specific, especially in Southern California.
Thank you, Ray. I just wanted to say, Nicole wants to let us know that she said that gradual intermittent fasting has helped her help me slow much. I guess you mean slow things down. I started by waiting 12 hours between dinner and breakfast. I do intermittent fasting too. I agree. I know that some people can't do that, but I think it's helpful. So thank you, Nicole.
Yeah, I think we have to be careful when we're talking about insulin resistance and long duration fasts. I'm not sure how safe some of that is. I apologize. I'm not trying to judge anybody. I'm just.
No, it's good. It's good that you.
We always need to consult with the
Absolutely.
doctor.
Absolutely. Absolutely.
Yes.
Dr. D'Angelo? No, I'm just kidding.
And a doctor.
Okay. So Stevenson has come back and asked, wait, is the Epstein-Barr virus the one that is identified as causing mononucleosis?
So he answered his own question down later in the section.
Oh, he did? Okay, thank you for
Yeah,
that.
so
yeah, he did.
But again, we really don't know. There's thoughts that this is genetic. So if it's just underlying and something activates it, or if it gets activated with age, if it gets activated after injury, if it gets activated with insulin resistance, we don't know yet. And we could spend 100 years speculating, and it's not going to give us an answer. So the best thing to do, at least for my health and my mental health, has been just, really focusing on how do I manage this instead of, going down the rabbit hole of what caused it.
Wow. Yeah. And Jeff says, wow, funny you say this. I got mono as a teenager and not long after I started seeing lipomas. Yeah, we've heard that.
And then we hear about people getting lipomas after stressful.
Yeah.
We know about the trauma. Most of my patients have had some form of trauma.
Yeah.
But I often have a patient say, I went through tremendous stress and then I got these lipomas. So we just don't know enough, do we?
I think Dr. D'Angelo is very correct in saying that as we research, and it's already happening, everybody, really, it's already happening, that we're finding these things earlier. It used to be when someone found our group, they were in their late 50s or early 60s. That's not the case today. So, I think things are improving. I think it shows where we're going.
I think one of the most powerful answers you can give to a question such as this is I don't know.
Yeah.
Because we really don't. And I think we all need to be a little bit more comfortable saying we don't know. There's still so much unknown out there, and we don't want to give speculations. We don't want to, give answers that might not be right. So in that case, it's better to be hesitant until the research really comes out.
So true. So Diane, how do you get your doctor interested in learning more about Dercum's disease? Or is it better just to travel to the doctor who is already an expert? I've already said mine, so does anybody else want to?
The Fat Disorder Resource Society does have a pamphlet on Dercum's disease. It's quite a good one. You can order them for nothing. And I think that we Dercum's disease answers should be creating ours as well.
Yes,
I
yes,
actually
we need
have
to.
mine in my wallet that I take with me everywhere, the little pamphlet from the FDRS, so that I can show the doctor, like, at least it's something that's printed out that looks like I'm not crazy. Look at this. I'm not
Yeah,
crazy.
look.
I really have been diagnosed with this.
That's awesome.
So
You know what, I would also suggest that you're going to need a local partner. So try to form a relationship with the primary. Do your best to try to introduce little things. It doesn't have to be all at once, but you're going to need a local partner. You're going to need that local help, somebody to sign, somebody to help you manage your disease. So, I always try to work where I'm at and then start thinking about broadly searching.
Okay. We've
got 2 minutes.
I know. I'm trying
Well,
to we have
knock, knock.
few more.
No, I'm joking. I think we're good. Let's wrap it.
You want to
Okay.
wrap it?
Yep.
Okay, and we won't ignore those though, you guys. We'll try to get these answered.
Yeah.
And some of them are just making comments, so that's good.
Well, no, make sure, and Dr.
Go ahead,
Derek
Lauren.
was here as well.
Hi,
We
Dr.
had
Derek.
problems getting in over, but let's make sure and note that she was here. Thank you very much, Dr. Derek.
Linda Ann, thank you. That was a
Linda
wonderful
Ann, you're the
presentation.
best.
So much.
Yay!
Thank you. Thank you
All
all
right.
for what you do. And thank you, Ray. Mostly thank you.
Yes,
Very sweet. Thank you.
very much so.
All right. Good night, everyone. We'll
Good
have
night,
the recording out.
everybody.
We'll have the recording out. That's important. And the presentation, all of
Yeah.
that will come out. So, okay, Lauren,
Thanks, Juanita. Bye.
bye. Thank you. Bye, guys.